the stenting and coarctation of aorta in adults by Dr. Krishna Kumar.
Thank you, Chairperson. Thank you, Nageshwar Rao and to Srinivas for having invited me. It's been a little tight, and we were quite busy with the IFISH conference that I think many of you may have attended last week. Close on heels, and I see a very big audience here as well. And so there is obviously a lot of interest, that means. This topic, I'll give it a little different twist. Since I'm a pediatric cardiologist, I have to tell you that I deal primarily with newborns and infants and some older children. But can you tell me how this works? All right, never mind. So essentially, we do have a significant adolescent population with coarctation that we deal with. And they're different. They're different, I think, in some ways in pathology, and there are many other age-specific considerations. A little bit about the anatomy, simple terminology that we follow for coarctation and the various segments that we talk about. This is the ascending aorta, which is till the takeoff of the innominate. The transverse arch is between the innominate and the left common carotid, and distal to that is the distal arch, and starting from the left subclavian is the isthmus. And this isthmic segment may be very different in different patients. There's a lot of variability in the anatomy, and that dictates to some extent what kind of stent we use and how we place it. So this is the landing zone, so to speak, of the stent. We need to actually have it sitting right here. And sometimes at the landing zone, you have the subclavian coming off. The treatment options, these are traditional treatment options we should talk about, and they are real alternatives, surgery, and there are proponents of surgery who get very good results, and there are very recent publications that come that have fairly substantial numbers, so it shows that there are many people who still believe surgery can be done. Balloon alone, and there are many proponents of this, and I'm going to speak a little in its defense. And then there are stents which are plain or covered stents. Surgery, as recently as 2010, there is a very large series that has been published on surgery in adults with coarctation. Recoarctation is rare, aneurysm is rare. This X-ray shows you the example of rib notching, which is typical of older patients. And it has a bearing on the surgeon's approach to coarctation. It does carry some mortality in patients who are older, but I don't know if this is a recent bit of data. I think more recent series doesn't show any significant mortality. There's also a risk of paraplegia, and there are a few other complications that are well known and well described in coarctation. The surgeons don't like this lesion because of the extraordinary amount of collaterals on the way to approaching the lesion in the thoracic cavity, as a result of which they actually are happy to hand it over to us. This is one of those lesions they don't mind not operating, especially in adults. And patch repair in some cases definitely has been associated with aneurysms, so surgery is not necessarily always free of aneurysms, although many recent series don't seem to show that. How about balloon alone? It's convenient, it's very inexpensive, especially in a country like ours where stents are very costly. It's technically very easy. There's excellent immediate results in discrete coarctation, and long-term follow-up is available, encouraging, in fact, if the initial results are good. Downsides, there is elastic recoil which cannot be predictably avoided. There is residual gradients that are common, and there is potential for disaster if you don't size your balloon right. And I think in general rule we follow is we don't go beyond 16 millimeters. No matter what the size of the isthmus or the surrounding tissue is, we don't exceed 16. That's the rule of thumb that I follow for balloons. Aneurysms have been described on follow-up, but I have got some good data on follow-up. So here's an example, discrete coarctation almost amounting to a tree of interruption, balloon, and you have a pretty good result. It doesn't look as pretty as a stent, but then it's good enough. It eliminated the gradient in this particular case. And there's great data available, much better than stents. There's a 10-year follow-up study from Saudi Arabia that was published in JACC, whereby one of my very good friends, Dr. Omar Galal and Dr. Fauzi, And this data showed a sustained reduction in gradient at repeat cath. Only 3 repeat required dilatation. A tiny aneurysm at 1 year did not progress in 3 patients. There were no new aneurysms. All these patients were very well followed up, documented, and 27 out of 37 were normotensive at rest on no medication. Stents. Okay, the logic is that it buttresses the dilated segments, eliminates the elastic recoil, and eliminates gradients in most cases. But we don't have data very much, and there are many examples of aneurysms that form on the edges of the stent. It doesn't, in many situations, it's not necessarily associated with lower procedural complications, and we are completely unsure about the long-term effects. It's purely in terms of intuition, stents are stiff, metallic, and the length of the stent could be quite long in some situations, and that segment is not going to pulsate, and it's going to come in the way of propagation of the normal pulse wave that goes down from ascending to descending aorta. In surgery, this area of relative stiffness is the discrete scar of the surgeon, of the site. And in balloon, perhaps there is minimal injury, but there is potentially incomplete relief. So I don't know if there is very much by way of choice, particularly between balloon and stent. But we all have this problem, don't we? We don't like simplifying medicine. We don't like to accept. We tend to undervalue the old as we seek the new. And I think that's a story that we keep seeing. We do MRIs and CTs when echo would be adequate, and we've embraced the drug-eluting stent when many situations bare metal stents would be adequate. So similarly, we've all embraced stenting of coact when actually balloon may actually be better in some circumstances. We don't have data. We need data. So we embraced the new and expensive technology just for the sake of it. I'm just throwing up this thought for all of us to think about, because I'm not so sure I'm not completely convinced that stenting in coarctation is the right way to go about it. The key issues really are therefore indications, and in discrete coarctation I'm not so sure if we have a good case, but if you have a diffuse stenosis that doesn't yield well to balloon, of course you can stent it. Then there's the issue of balloon expandable versus self-expanding. Self-expanding stents have been largely given up. It's balloon expandable in most situations. Covered versus uncovered stent, the debate is still on. When covered stent came, a lot of people embraced the covered stent, but there are some significant issues. You can't just do it in everybody. There's other hardware that came along for coarct, but seems pretty unnecessary, like the bib balloon. Of course, the marker pigtail is very useful, but the bib balloon, I'm not so sure. The most important thing is strategy, how you plan your case, and I'm going to show you 2 case examples that will illustrate that point. To be aware of the complications, and the most important thing is to be able to meticulously follow up your patients. So here is the purpose of showing you these case examples is perhaps to indicate how we've been selecting our cases for stenting. I'm not so sure if everybody agrees with the indications that we follow, but I think these are 2 cases that are interesting that'll just throw up a lot of thoughts. So here's a patient who had severe aortic regurgitation from a bicommissural aortic valve, coarctation, severe ventricular dysfunction. Balloon was attempted. The gradient came down with incomplete relief. And you can see that the isthmic segment is actually pretty small and narrow. And what's interesting is an incredible amount of distortion at this particular site. The surgeons did not want to repair the coarctation in combination with the aortic valve replacement, so they suggested we do something. And the repeat caths showed a 40 millimeter gradient across the segment, and we realized that the AR was being exaggerated greatly by the presence of a coarctation. So we went ahead and stented the coarct. So the usual, there's nothing spectacular. We took a relatively short segment stent for a specific reason, and you can see that the stent is being deployed. And what's interesting is what you see here. The stented segment you see is continuing to move, and perhaps in this particular case we followed him for a long time and there hasn't been a long-term complication at the coarct site, but this gets you a little worried because the amount of movement that you see in the lower border of the stent, and you're worried that the metallic ends of the stent do not damage the adjacent intima. But in any case, this patient did really well. He improved dramatically and underwent aortic valve replacement 3 months after the stenting. So in this particular case, stenting allowed us to eliminate gradients, which was very important for this patient. Another case which I think is in some ways extraordinary, because I don't know if it's ever been done before. It's a 25-week-old twin gestation who had incidental diagnosis of congenital heart disease with an irregular rhythm, low pulses. Echo showed a discrete subclavian coarctation with normal ventricular function. MRI confirmed it. She was pregnant, and echo showed a very high, very severe coarctation. She's had a history that suggested that she wasn't willing for termination of pregnancy because she went through a treatment of infertility to get pregnant. The recommendation was that was not acceptable. Medical management, we found it very severe, although it's been documented that you can proceed with medical management during pregnancy. Surgery, too unsafe. Balloon dilation, we were worried about the status of vascular tissue during pregnancy, the presence of progesterone. So we went ahead with stenting. We thought of covered versus uncovered stent, and in this particular case, the subclavian artery would get occluded if you had seen the MRI that was right at the site of the coarctation. And that's another consideration when you use covered stent. We can't just take up covered stent just because it's there. If there is a very close by subclavian artery, one has to not use covered stents. So we went ahead with a bare stent, but we have to be very careful in planning hardware in such circumstances. So it's always a good idea to get radial access, and I find that it's a very good opportunity to be very precise about your stenting. And then, of course, we had these wires that we passed and took a 11 French sheath. We didn't do any angiograms. We took the stent, the balloon, the sheath right at the point which we knew as was available from the radial artery catheter. So we just performed fluoroscopy only, no angiograms were done. So this is the first angiogram and the only angiogram that we obtained. And this is 2 injections simultaneously, one from the catheter that's passed into the subclavian. Notice that the subclavian is right at the coarct site, and the other one is from the sheath below, telling you where you are. And then we went ahead and proceeded with stenting this segment. And I'll skip this. And we didn't do any angiograms thereafter. So after that, we noticed that there was no residual gradient. We could limit the fluoroscopy time to 90 seconds. And of course, we had a very good result. Now, the purpose of showing you this is twofold. Of course, it's a very unusual case, but it's also to show you that coarct stenting can be really simplified. If you got your alternative modalities of imaging and you know where you are, it's a procedure that's actually very straightforward. And it's not the technicality of doing it which makes it interesting. It's understanding the indications and understanding what we are doing and what happens during follow-up. This particular patient did well. There was slight hypertension initially, but she went on to deliver a twin babies and is doing very well 2 years down the road. So this is the typical story with coarctation. Again, an example of how a covered stent won't work in this particular circumstance where the subclavian is absolutely bang close to the site of the coarctation. So you have to individualize in these circumstances. Now, complications, of course, it can happen. Stent displacement in our case, and it happened in one very discrete coarctation. The stent expanded and seemed to sit beautifully, but the segment gave away completely and the stent had to be deployed, fell into the descending thoracic aorta and had to be deployed at the level of the diaphragm. So for very discrete coarctation, occasionally you can get into that situation, particularly if your isthmus is very large. The rupture we haven't had, but it's well documented in literature, and you need to distinguish between coarctation and middle aortic syndrome, which is in association with neurofibromatosis or occasional cases with Williams syndrome or aortoarthritis. There, the aorta is far more vulnerable. It looks superficially like coarctation, but it can rupture. Bleeding and hematoma, you've got to be very careful. And aneurysm formation, which is, I think, underreported. We, for example, haven't done adequate MRI or CT on follow-up. About cardiac surgical backup, I'm not so sure. Always good to do interventions under cardiac surgical backup, but I'm not so sure when things go wrong how much the surgeon can bail you out. Covered stents are a more realistic bailout, and I think it should be on shelf whenever you dilate coarcts, even if you don't use them primarily. And the most important thing is to follow up. If you have platinum stents, then you can use MRI, otherwise CT. And I think lifelong complications can occur, so you have to follow up lifelong. residual hypertension, aortic valve problems, ascending aortic dilatation, berry aneurysm, nothing is resolved with stenting. None of this goes away. So you have to be very, very careful with follow-up. So these are some data on illustrating that there isn't much point in delaying treatment with coarctation because survival can be limited with that. And of course, residual hypertension increases with age. So I'll just summarize in the last few slides. Our institutional policy for newborns and infants is surgery because recurrence after balloon dilation is almost inevitable, especially in newborns. Older children, we use either surgery or plain balloon dilation, which works very well. Adolescents and adults, I think for discrete coarctation, still, there is no reason to abandon the balloon. For long segment, small isthmus, and for poor initial response to ballooning alone, of course, stenting is a good option. And again, it's the question of selecting your cases and doing it specifically tailored to the patient.